morning, everyone. I thank AIOS and my chief instructor as well as co-instructors for giving me the opportunity to present this part of the presentation. So this is role of naming and meshing in uveitis case workup. As Dr. Saminder has already emphasized that majority of the diagnosis can be made in uveitis can be made on a good history taking and clinical examination. So I will be focusing on this part, the history and examination. So as far as naming and meshing in uveitis case workup is concerned, why is it is so important? Because the uveitis is a entity which is associated with numerous disease associations. There can be varied etiologies of the disease. It can be infectious, non-infectious, immune-mediated, and the main thing which comes in the differentials are that similar disease can be similar clinical signs and symptoms will be present in almost all the entities. Also, it can have a systemic involvement, or the disease can be limited to the eye only. So the diagnosis is challenging. So how we are going to solve this problem in uveitis? The important part is differentiating the etiology of uveitis mainly on the basis of ocular history, systemic history, and disease course. Also is important is the review of symptoms and signs and which are obtained on a detailed ocular examination. Very important is to classify the intraocular inflammation. The classification will help us in reaching the diagnosis in most of the times. And also the support from laboratory as well as imaging examinations, as sir has previously emphasized. So in order to solve a problem, we first need to name the problem. So in this technique was introduced almost 35 years back by Nozick, which is naming on the basis of the ocular history and examination. And first the naming is defining the problem and deriving at a clinical diagnosis. And meshing is comparing all the entities which have in the patterns are compared, which will help us to reaching a provisional diagnosis first and then the final diagnosis. So what naming comprises? So we have to look at the age, gender, what is the race, severity, what is the chronicity of the attacks, what is the laterality, and what is the pathology. And again, location of the inflammation is the most important thing. So just going through this part of the presentation. So as soon as the patient walks into the clinic, there will be certain things from the history only which will be pointing towards a certain diagnosis. Like in children, mostly GRA will be the consideration, or any parasitic uveitis. In old age, mostly the patients can have herpes zoster ophthalmicus, and Behçet's as well as HLA are mostly the diseases of the young. Similarly, in case of females, the autoimmune diseases are more common, and VKH disease is common. Also, certain diseases are common in certain races, like pigmented races will have more of sarcoid. Behçet's is common in Orientals, and Caucasians will have ankylosing spondylitis is common. Similarly, in our part of the world, socioeconomic status is very important, and certain diseases like leptospirosis, rheumatoid granulomas will be common in patients of lower socioeconomic strata. Also, ocular symptoms which the patient will be telling us may point towards, although this is not absolute, but they may point towards a certain diagnosis, like pain and redness will be more common in patients with anterior uveitis. Similarly, floaters will be common in intermediate uveitis, and mostly posterior uveitis will present with a decreased vision kind of a symptoms. So again, this part of the history is also important. What is the chronicity of the disease? Whether it is limited, that is less than 3 months, whether it is persistent, greater than 3 months, whether the disease has been acute, which is sudden onset with a limited duration, and whether it is recurrent, which is the repeated episodes of uveitis which are separated by periods of inactivity without treatment and are at least 3 months in duration. Similarly, chronic uveitis will be labeled when there is persistent uveitis after discontinuation of therapy. And then we have to see whether the attacks are mild, whether they are moderate or severe. Also, the pathology is very important, whether it is non-granulomatous or granulomatous, And coming to etiology, we have to differentiate whether these are infectious, non-infectious, traumatic, or it is a masquerade type of uveitis. Anatomic classification plays a very important role in differentiating the various uveitic entities, as we have to ascertain whether the disease is limited mostly to the anterior part of the eye, that is, it is having iridocyclitis or anterior cyclitis only. Intermediate uveitis in the form of a posterior scleritis or posterior cyclitis or pars planitis, and posterior disease in the form of a choroiditis, chororetinitis, or when all the parts of the eye is involved, which is a pan-uveitis kind of a thing. Also, as these two things are complementing each other, as we are looking at the patient, we are asking specific history, and similarly, we are looking for certain signs when we are examining the patient. From front to back of the eye, we will go in and look for the various things. What is the findings in the cornea? Is there any signs of an endothelitis, which will mostly point towards a viral etiology? Whether there are any granulomas on the conjunctiva, which will be more common in cases of sarcoid or ophthalmia nodosum. Similarly, we have to look for any iris atrophy, which points towards diagnosis of a viral uveitis. We have to pay attention to the anterior chamber details, look for any nodules on the iris surface or in the anterior chamber only. Similarly, whether the vitritis is focal or diffuse, that can also provide clues towards the diagnosis. Similarly, retinal involvement, whether that is focal, which is seen in SLE or Behçet's, and whether the retinitis diffuse, which is seen in case of an acute retinal necrosis. So essentially, we are dealing with something like this BTS group. So they all look similar. So we have to come to a specific diagnosis, just like sir had shown a few cases of hypopyon uveitis. So I'll be showing these two cases. So this is the chart which is I have borrowed from PGI Chandigarh. So what this is chart which helps in the naming and meshing, which is a topic. So this was a 30-year-old female who had recurrent episodes of inflammation in the anterior chamber in the right eye. So a typical this hypopyon can be seen, and this is the photo which has been taken after the patient was laid to one side. So we can see that the hypopyon is shifted. So some histories we have to take after examining the patient under the slit lamp. So this was 30-year-old female, aged in Indian, which was a severe type of uveitis. She gave history of recurrent attacks. It was unilateral. As we can see, this was a non-granulomatous type of inflammation, and there was hypopyon and fibrin in the anterior chamber. So this is the template which helps us to arriving at a diagnosis. So as we are seeing the patient, we are comparing with the known things which can be there in the differential diagnosis. That is it endogenous endophthalmitis? No, there is no such kind of history of any diabetes or previous hospitalization. Then we will ask about any history of backache. So that is also not there. So this naming and meshing will help us in reaching the diagnosis in mostly 70 to 80% of the cases and limit our investigations. A similar patient with a hypopyon uveitis, fibrin in the anterior chamber, but for this patient he had specific history of backache. So a simple HLA-B27 test and starting the patient on steroids can help us in managing the patient in a positive direction. Thank you so much for your